All right, we're going to get started. Do you need the attendance of who's on the line?
Yes.
All right. If you're on the line, can you please announce yourselves for attendance purposes?
Donna Kennedy. And Budai Deb. Sarah Connolly. Greg Youngsdale.
Is your Wi-Fi in here?
There is, but I don't know what the password is.
Oh, Wilson, I'll start it. I got Phil and Ron. Anybody else?
Jason Borton.
All right. Dr. Bird, are you on the line? No. How about Dr. Lamoth or Dr. Teuscher? All right. So in your packet there, you'll see the minutes from the last meeting. If you haven't had a chance to take a look, please take a look through and see if there's any corrections or additions. If there's any corrections, otherwise we'll entertain a motion to accept the minutes as they are. First on the agenda is going to be the CMAC SEMSCO report. There has not been a CMAC or SEMSCO meeting since the last WREMAC meeting, so we'll move on. I'm going to go past my chairman's report and we'll bring up some issues as we go on into old and new business later. Last meeting we did talk about some of our standing committees on the agenda and changing some of those, specifically related to pre-hospital committee, which we had taken off, the trauma advisory committee, which we have representatives from the staff here, as well as the nurse advisory committee, which there are some new members interested in participating in. So moving down the list, we'll start with the trauma advisory committee. And Beth? And anybody, as you're giving a report, I'll ask you to come sit in this fancy chair next to me so they can hear you on the other end of the phone.
ECMC's trauma program was reviewed by the American College of Surgeons on March 10th and 11th. We're very pleased to say that the reviewers are recommending designation as a level 1 trauma center. We will not receive our official confirmation for at least 12 weeks for paperwork processing. There will be an RTAC meeting planned on April 9th at 10 o'clock. We'll be discussing data related to transferring patients to the trauma centers as well as other topics. And also just wanted to add, ECMC, Strong, and Upstate Trauma Center are collaborating on a conference. It'll be held May 5th, Trauma Reach Conference, in, at the Finger Lakes Gaming and Racing Facility is where we're going to have it. So that's it. Thanks.
All right. Thank you very much. Next is the Nurse Advisory Committee report. Dr. Lynch, do you have anything you want to say about that?
At the last meeting, did we formally agree that we're going to keep that? And I think someone was going to reach out to Donna Ottawa about not.
Well, I don't think Donna's been at the meeting in the last couple of years. I don't know if anyone knows if she has any interest in staying.
She doesn't.
She does not?
I thought we decided that you were going to ask the individuals.
Okay. Right.
Brian, we couldn't hear what was said.
I think we can just summarize.
I can give a little bit of an update on that too.
All right. Do you want to come on up here?
Yeah. So, I knew you were. Mayor Rostram contacted me thinking that I was going to be the new representative. So I have had contact with Chris Moden. He was going to reach out to Donna Odo to see if she wanted to continue, and then he is willing to take it on and restart it up.
Okay.
I will get him in the loop and I'll keep you.
All right. So is he going to be taking over as the chairman of that committee?
I will ask him if there's no one else who.
That was the same thing.
He was willing to.
Willing to?
Okay.
Well, then I think that we should get the interested parties together, if you don't mind coordinating that, and then unless there is anybody else that's interested in being the chairman, then perhaps you would be a fine candidate. While we're on the subject, if anybody's interested in meeting the REMAC chairman, we'll entertain those, those motions now as well.
Don't do it, I don't recommend it.
Hey, quiet down. Before we go on to the program agency committee meetings, I do want to just introduce Dr. Rich Ellman for a second. I don't know that Rich has been at a REMAC meeting recently, so if you want to just introduce yourself real quick to the
I'm
group.
Rich Allman. I'm chairman of the emergency department at Mercy Hospital, Buffalo. Many know me already.
Thank you. That being said, we'll go on to the program agency reports, starting with Lake Plains.
Pretty much for our trainings, you can always check our website. We always post them on there, even out of area trainings as well. Just a BLS Narcan request from Wolfwittsville. We mailed out the REMAC protocol updates. 27 were mailed out. 22 have been returned with the confirmation. 4 of those are Buffalo General, ECMC, Kenmore, and Medina. We just didn't get no response back from them. Just a pad request from Town and Country, and a reminder that the REMAC annual skills is approaching fast. We're getting some more skills sessions set up. Next one coming up is in Niagara County. That's on March 30th. Pretty much, another big thing for Big Lakes, they had a change in leadership. The chair now is John Malinchuk, and the vice chair is Steve Cooley. That's about it.
All right. Next is STEMS.
Staff attended the Southwestern Regional Emergency Meeting on April 4th. The next meeting is scheduled for April 1st. We attended the Cataract County Council meeting on February 9th. The next one is scheduled for April 6th. We attended a report to the Stockton County Council meeting on March 11th. The next meeting is scheduled for May 13th. And we attended the Allegheny County Council meeting on March 12th. And the next one is scheduled for May 14th. We only have a couple late PCRs this month. We currently have 12 agencies in the process of adopting PCR and 34 agencies in our region that are currently live. We hosted a QA/QI class on Tuesday, January 27th at All-Star Training Center and also at Olean General Hospital. We had over 50 providers from Cross New England attend that class. We assisted in setting up an international trauma life support class that was held at Crossroads Training Center in Belmont on February 17th. The spring training is coming up here after next weekend. We're very excited about that. We currently have full registration, and our focus this year is on trauma, and we're very excited about that. We think it's going to be a great presentation. We are hosting a stroke class on Wednesday, April 8th. It will be live at Olean General Hospital. We'll offer through distance learning at All-Star EMS Training Center and also Jones Memorial Hospital. It's being presented and sponsored by Dave Saskula Institute Stroke Center. We have an Narcan training scheduled on April 15th at Olean General Hospital at the Education Center, and will be presented by Tracy Reed of the Southern Tier Overdose Prevention Program. We have a CLI class scheduled for May 16th and 17th, and a big training for that class scheduled for April 20th at Olean General, and then also at All-Star EMS Training Center on April 29th. Visit the website or contact us if you'd like to get registered for the free training. We have 7 skills fairs set for spring throughout the region. At the bottom of the report is a list of dates and times and locations for all of those. We'd like to hold a preceptor class if we have enough interest in one, so please contact us. Let us know if you'd like to have a preceptor, if you have any questions, we can help you with that. We're collecting still the HCS account registration for the region. We are almost there. We still have a few agencies left that have not submitted yet, so if you see an agency that's looking, you can assist us or have them contact us, and we would definitely help them finish that up. And that's about it. Thank you.
Thank you, Jen. OPC? Yeah, please.
I know we have a jam-packed meeting, so I'm going to pretty much just hit a very few high points. The majority of the information is in our report. One of the things that we're proud of, we completed an EMS officer training course. We had 103 providers throughout the region who attended that, and that's really doubled in size 1 year over the last. So that was a good thing for us. We have started conducting a number of REMAC credentialing CME program on-site reviews at agencies. We've had some really some reviews that have gone very well. We've had other ones that there's a lot of work to be done. And so we're continuing to provide after-action reports to the agencies to try to get them up to snuff with regard to records that they need to maintain within the agencies, specific to their provider training, the annual skills, and also their alphabet soup classes to make sure that everything is up to snuff. We are continuing to do this. Our goal is to hit every agency in the Wyoming Erie region over a 2-year period. As you can imagine, it's a very, very extensive task to be able to do that. That's I think about 101 agencies that we have to hit between the two counties. So we are intending to host a certified instructor update course on June 8th and 15th. We have a tentative location, but I don't want to announce it yet just because it may fall through. But for those instructors who need a CIU course, we do have one scheduled. We've split it over 2 days, 3 hours each day. It'll be on a Monday night for 3 hours each. That way, people who teach on Saturdays are still able to get the training in, and Monday nights seem to work well for most instructors based on the programs in the region. Our conference is coming up on April 18th and 19th at the Millennium Hotel in Cheektowaga. We're hoping that providers in the region continue to support this program. It's a $95 conference for almost 2 days, and many of the presenters that we have at our conference are presenters that you see at some of the bigger conferences on a national level. So we hope people continue to support that. The Wyoming Erie Regional EMS Council has approved the recommendation for Dr. Krawczak to replace Dr. Brown as the representative for St. Joseph's Hospital. So the REMAC is going to need to take official action on that today to get Chris as a member. And the last thing is the program agencies were asked by the REMAC at the previous meeting, I don't know if you want to do this now, but to review the number of intermediate services that are in the area that are going to be affected by the June 30th sunset of the intermediate level of care, and also to evaluate the number of providers who are affected by this. In my report is a list of all of the agencies, and what we did is we actually went back a little bit further than the previous meeting. We went back over the previous year for any agency that had been certified at the intermediate level, really any time in the recent past, last year and a half. We've included them in this report. There are 3 intermediate services that prior to today's meeting dropped from intermediate to basic level service. There are 5 that went from intermediate to AEMT, and then we have a handful of others, about 10 or so more, that are in the process of declaring whether they're going to go to AEMT or if they're going to drop back to BLS level. There are a few that are still undecided. They are aware of the June 30th deadline. They are aware that the REMAC has to take a formal action on this, in that the last meeting to do that will be at the June meeting before the summer session. Also, after that report is the list of providers who are registered with us in our database. So we have a PPA on file for all these providers. There's 173 intermediates that are registered as in our system with PPAs at the intermediate level. We know that 33 of those providers are no longer certified at the intermediate level. They've either dropped back to BLS or they have increased to the paramedic level of care. The agency just hasn't filed an updated PPA with us. So what we're anticipating is that, based on our numbers, there are 140 intermediates between Erie and Wyoming County that will need to drop back to the BLS level of care as of June 30th. One of the things that might be a little bit confusing, and we're trying to close the loop on this, is that many of these providers have their certifications have expiration dates at the intermediate level beyond June 30th. So it's going to provide a little bit of a challenge, but it shouldn't be too bad because the agencies, as long as the agencies are aware and they get the equipment off of the rig, if they're not going to be at that level any longer, that won't be a problem. The problem is going to be the paramedic level services or those that go to AEMT who have intermediates that are still in there that are going to want to still have access to IV supplies, intubation supplies, etc. That's going to be a little bit of a challenge with us, and I'm open to suggestions on how we can close the loop. I haven't come up with any great ideas, I don't think, yet. So I don't want to make trouble where there isn't any, maybe there
No,
isn't
this
any.
comes up on the agenda later, so, and I think it's an important point. So, from Big Lakes, do you know about how many providers you still have at the intermediate level, and how many, more importantly, agencies that have not switched yet?
Yeah, I would have to double check.
You said about 10 agencies that haven't moved one way or the other,
Yeah, I can-
give or take.
I can count it.
Donna, how many agencies do you have, or Jen?
We had 2 agencies that were still needing to move. One did, the other one is going to downgrade, and those are the numbers that are doing the paperwork.
Okay, so they're addressing it and aware of it. We had discussed this, I think, back, I don't know, a year or so, probably 2 years ago, going back about the transition from the intermediate level, and we had come up with some wording and things at the time. It gets a little convoluted because there are some contradictory policies that came out from the state with different dates on them, which confuses things, as well as the fact that there are actually intermediate cards that were issued by the state that are valid until February of 2017. Correct?
Yes, sir, that is an accurate statement.
Thank you. So, given that fact, it evidently falls upon the WREMAC to take care of this. And I think, we had put some wording together in the past about the transitioning. And I think to your point of how we address this, I think the easiest way would be to re-solidify that statement that we had initially come up with last year with timeframes, a memo to go out to all the agencies that we disseminate. I'm going to read you a suggested draft policy that was put together. This is a combination of both wording out of the letters from Andy Johnson from the state over the last couple of years, as well as from some prior language that was discussed at our meetings over the last year. As you are aware, as of June of 2012, the New York State Bureau of EMS made the decision to transition to the National EMS Education Standards. In doing so, the New York State AEMT Intermediate level of care has been moved up to the National AEMT scope of practice. Per Bureau of EMS policies and notifications, all current certified AEMT intermediate providers must be certified under the new standards by June 30th of 2015. And that's the date that comes out of the most recent letter from Andy Johnson. With this advancement to the National EMT scope of practice, agencies that utilize the current New York State EMT intermediate level will need to make one of the following decisions: advance to the new AEMT scope of practice, 2, move to either critical care or paramedic level, or 3, move to the EMT level and no longer provide ALS services. Due to this policy, the AEMT level of care will be removed from the WREMAC protocols as of June 30th, 2015. Any provider with a valid New York State AEMT intermediate card after that date may only practice up to the EMT basic level of care. Any agency currently certified at the AEMT intermediate level must also submit a level of care change to move up to one of the ALS levels or down to the BS level as outlined above by that date. Are there any suggestions or comments regarding that? Will that meet your needs?
Yeah, I think the biggest issue that we see here is we only know what we're told. And so if we don't have provider privilege applications on file for people, yet they are out in the system, I think those are the people. I'm not worried about the people we know about. I'm worried about the people we don't know about. And it's so easy to offer things for other people to do, but I think what would be helpful is if there could be some type of communication from the Bureau to these people who are certified in their database with an expiration date beyond June 30th. I don't know if that's possible, but it just seems like if we could try to close the loop one way.
You lost him at Bureau.
He looks like everyone's staring him down.
I happen to be listening.
Oh, thank you.
Do you want a list of all those folks that are certified intermediate after June 30th?
Well, that might be helpful, but it almost seems like if there was a way, even out of the central office, to generate a letter that goes, I don't even statewide, to everybody that has a car, to all intermediates with an expiration date beyond June 30th, that notifies them that their certification is only valid to the BLS level.
So sort of a reminder.
Yes,
the dates
just to
coming.
close the loop, because we may not have a PPA on file, but yet in your database, you know where, you may not know where they practice, but you know who they are.
Yeah.
Yeah,
If we can get, I can't generate a list
Right,
like that,
right.
but I believe central office can. So at the very least, we can do that for the region, and I'll suggest it to Andy for the state.
okay.
I mean, most of them are in our region, but there may be
Right.
people who are registered to a home address outside our region, who
Yeah.
practice in our region.
Yeah.
So it would be helpful, they did for everybody, because
Yeah.
probably should be there.
It's a good idea.
That's all I have.
Regarding that, that memo that I just wrote, is there any commentary or discussion about the wording of that?
I guess my only recommendation was that if people take no action, they should, I don't know if that was in your change or not.
It was not.
I think if an agency takes no action, we should drop them to basic. That makes it easier. We should still chase them down later on to do the paperwork, but I think effective the date, they should be a basic agency.
From the state level, if we put out a memo that says that there's no, we're taking the intermediates out of our REMAC protocols, and if you do not respond, your agency will be dropped to the BLS level, is there any issue from?
No, I mean, I think that's gonna be, I don't know what central office's, method, will be to officially do that transition in our, on our official database, but generally, the belief will be similar to if we have a lapsed agency, we would almost consider it, the protocols have sunsetted, so everybody that's in that category will likely default back to, EMT level unless we get notification A from the REMAC and B from the agency medical director, which requires both to make a change in that database, to upgrade them. So that would be the appropriate way to do it.
It would be helpful though if you could list the agencies out, because central office, what they do is make a copy of your minutes
Yep.
and they
Right.
pop it in that file for that agency, so if you don't list them out, I don't think.
So when we come back from the summer, there'll be enough time to try to track down agencies or whatever, and then if it's okay with you, Brian, at
I
the
think
September
that's fine.
meeting, we'll then approve the list of people we haven't heard
Yeah.
from,
I
word out basis.
think we should be a little bit more proactive than that. If we don't know if we have outstanding agencies by the June meeting, it should be with an automatic as of July 1st. Because
Fine,
it sunsets in,
I mean, theoretically, someone could still put the paperwork in on June 29th.
So typically what we've done in the past is that over the summer break, we've authorized the REMAC chair to approve level of care changes in the interim over that break, and I think that that would be.
Sure. July 2nd.
and incidentally, the ones that are undeclared in our region are ones that are taking the AEMT test, they're waiting their test results. And the ones who know that they don't have any AEMTs in the agency, they know that they have to go BLS, because you have to have at least somebody at that level or higher in your agency.
And are there any concerns about us sending out this memo? We need to vote on that. You're just restating the state
Yeah,
policy?
we're doing anything different.
Okay. All right, moving on, ALS protocols, the subcommittee reports, ALS protocols, do you want to save that for the protocol update report? Sure. Okay. QI, Dr. Kenyon is not on the phone, but I don't believe there have been any issues, unless Karen knows any that I'm not aware of. Okay. The national standards, that kind of goes along with the protocol, so we'll keep moving down to old business, which brings us to the proposed protocol changes. I think everyone has received the suggested changes, and both the letter and the updated highlighted protocols. There were some actually pretty good feedback. I have to say that whoever that the program agencies, when they sent out these protocols to be reviewed, they did a good job, because I saw responses from physicians, from hospitals, from providers, actually, which was very important at all levels of care, and from every region, from all three regions, which was very good. There were a couple of things that were brought up that I'll kind of just go through. We've talked about the CPAP changes. There was a couple of suggestions. One was to standardize the wording between the protocols, because there were some discrepancies, so that has been done. There was also a question regarding the way the protocol is right now. It says appropriately credentialed, and I think that wording was taken out of an existing policy, and the question was what is appropriately, and since we allow that to be defined and credentialed by the medical director, the suggestion was to remove appropriately and just leave it as credentialed, and take the word appropriately out. Any concerns about that, removing that word? No. A lot of these are just, there were some simple grammatical changes, comma changes and things, which I will not go through in the interest of time. There was a couple of concerns or questions brought up about the actual several things, and I'll read them. The first one was about the asthma protocol and the anaphylaxis protocol regarding epinephrine on standing order. It currently is in the anaphylaxis protocol, but it's not in the asthma protocol. And the suggestion was that if we allow it on standing order in one, it should be allowed on standing order in both of those.
This is for adult or pediatric?
This is specifically for adult, although I guess we could entertain discussions for both of these. And I'll give you the, so it is in, we do have it on standing order for anaphylaxis. It is in the collaboratives under standing order for asthma as well.
Adult and pediatric both, or just adult?
I believe just adult right now. No comments. All right, so I'll give you the case that was brought up. This actually came from a paramedic from a provider, and the question was whether it should be in standing orders. And the case was something to the effect of somebody with known asthma has had an exacerbation for a couple of days. They're short of breath. They call 911. You get there. The family says they've been wheezing all day. They took their nebulizers. Now you get there. They're unresponsive. They're passed out, and they're not breathing. You intubate them. Should you have to call for medical direction? Is this someone that would appropriately be giving IM epinephrine in this instance?
Why don't we ask the A&T instructors what they're teaching?
Epinephrine is not part of the AEMT protocol. Not even as a standing order. It's not inside their scope of practice. We teach them under pharmacology that it is possible. We teach them why it can be used for asthma, but it is not. It is outside of their wheelhouse for the national standards.
IM epinephrine in general, or
for asthma?
For asthma.
They know that it's indicated, but it is outside their scope of practice.
So I guess my question would be, why is it outside their scope of practice? If they can give epinephrine IM for anaphylaxis,
right?
Why is it outside the scope of practice for?
Yes, per the protocol and with the national standards, it's not something that's recommended for them. I have no problem. I think that would be something better. That would be a medical control option. I don't know necessarily that at the AEMT level that would be something that should be a standing order. It's not a standing order at the paramedic level.
That's correct. And so the question is, should it be a standing order at either or both levels? I guess, so just for, maybe you can, Denise, explain. So the national standards, when they define the scope of practice, isn't it on medications and routes of administration, or do they specifically define under specific disease processes and protocols?
It is medications and routes of administration, but they do not, right now, the way it is set up is epinephrine is not indicated at that level for acute asthma,
okay,
or for status asthmaticus. We teach it. I teach it. That it's a possibility, but they're not using it right now.
Is it a medical direction option now?
It's a medical direction option right now.
Leaving it that way for these other protocols. Probably the right.
Should it be then standing order at the paramedic level?
Just leaving it the way it is for now is probably the right thing to do.
We've had a number of quality issues in years past, with specifically regarding epi.
Okay.
I think it's like you're saying, because historically those got rid of everyone inappropriately given medication in the field.
I would agree that most of the asthmatic patients that we see get nebs and turn around, and maybe you could argue for CPAP in there. Right. Any other discussion? No? All right, so the consensus is to leave the epinephrine and the asthma protocol the way that it is and not change it. Just for a point of discussion, and maybe it's something we need to think about, is that it is on standing order in the collaborative protocols, and as we go forward next year, we may want to think about either adopting it at that point or having further discussions about that.
And I think these, as we go through the collaboratives, I think as we find some of these discrepancies that our region doesn't agree with or don't understand the rationale behind why it shows it, that's our chance to chime in and discuss it with the other docs and the other.
Sure. All right, so that will stay the same. What I'm gonna do is go through all these changes, we'll discuss them all, and then if we seem to have consensus, we'll vote and accept the protocol changes all in mass at the end. Is that fair?
Yeah.
Okay. The other question that was brought up was about for anaphylaxis at the paramedic level. This was to eliminate the medical control requirement for the second dose of epi. And I think that given these discussions, I think that while we agree that epi on standing order for anaphylaxis is acceptable, that then I'm going to think the consensus of the group is that if you get to the point where 10 minutes later you're giving a second dose, you probably should be calling medical control. Is that a fair assumption?
Yes.
Okay. Any comments there? Moving back to CPAP, just so we're all clear, although we've made some changes to the CPAP policy, that will only take effect once the state has officially rolled out the education and the BLS CPAP protocol. All right.
What's the starting pressure for CPAP?
The starting pressure in the proposed BLS protocol will be 10.
And we're going to change ours to meet that too?
We're going to change ours to 10 was the discussion last time, and to
This is
allow.
5 on here now, it says.
No, it should be 10.
The
It may have
old
been,
version said
the old
5.
version said, yeah, and it may, so the new one will say 10, which is what the state BLS policy will stay.
The other issue with those is all the disposable CPAP devices, you lose oxygenation when you hook into them, right? You drop from like 100% oxygen to like 35 or 40% oxygen. So to give someone a CPAP of 5, you're not giving them that much more pressure, and you're sacrificing all this oxygen.
Yeah.
So, so the suggestion was to start at 10 and then to allow from the AMT level on to titrate up every 5 minutes as tolerated if necessary. That was the discussion.
Is there a ceiling?
I believe 15 on those devices.
15.
What I read in here
There's
was
some that are
15,
20,
I don't
but
know
you're not
if
going
these
to
are.
get past 20.
The other discussion then was the way it was written last time, or in the policy that was disseminated, was allowing for, again, AMT level or higher to titrate down if they weren't able to tolerate a pressure of 10. And the way it had initially been written was every 5 minutes, and the suggestion from Dr. Kenyon was if they can't tolerate it, we probably shouldn't wait 5 minutes, we should titrate it down immediately. And so I think that sounds reasonable unless anyone has any difference of opinion. There were some questions about, someone brought up, one of the providers, about ipratropium and if duonebs were useful in asthma. And just as a point of clarification, there are several meta-analysis and Cochrane reviews on the utility of both using albuterol with ipratropium or duonebs in asthma exacerbations, that they actually do have improved clinical outcomes and decreased hospital admission rates. And so I think that that is appropriate. There were a couple of questions that came up from a BLS provider, and these are actually very good questions. One is about the chest pain protocol. Right now, it talks about assisting with nitroglycerin for basic providers. The current REMAC policy says that that they can be given if they have not taken an erectile dysfunction drug in the last 24 hours. However, the state protocol says within 72 hours. Now, right, a little longer acting. So the question was, do we feel strongly about that? Do we want to be different, or do we want them to be the same for consistency?
In the BLS section that says this, or the ALS section that says this?
This is in the BLS.
Well,
BLS protocol.
we need
This is to
no,
assist them
our
taking their
BLS
own
section,
nitro?
or their
Correct.
BLS. Right, it's in our BLS section though, too?
On our BLS section, correct.
Yeah, our BLS section is only designed to rehash what the state says.
So you want that to be 72?
Yeah. The idea of when we started putting BLS protocols in the ALS regional protocol was just to almost highlight like the best of kind of key points. So we should be moving that along to the same.
All right. The other question was regarding diabetic emergencies. And again, there's a difference between our adult and our pediatric REMAC protocol. One, first of all, the state policy makes a point of saying that you can, give another carbohydrate such as fruit juice, non-diet soda, etc. It's not specifically mentioned in the REMAC policy, which just says provide oral glucose 1 unit dose. And then in the pediatric protocol, we actually define what a unit dose is as 19 to 24 grams. The question was, should that dose be written in both, and should we allow in there some wording that would allow for another carbohydrate such as juice with sugar in it, cake frosting, something like that to be given. And since it is already in the BLS protocol, again, for consistency, which makes sense. If I actually looked at the collaborative protocol, if anyone is interested, and they actually say, they define, say, provide dosage, 1 unit dose defined as, 19 to 24 grams, and then comma, or available carbohydrate source to account for that, and that seems like a reasonable wording unless anybody wants to. All right, very good. The next point was, Donna, I'm going to make this your responsibility. If you look at our Narcan packet that's listed on the website, we have the old state policy in there, the old Narcan policy. If we can change that packet to include the new policy, please.
Yeah, we'll take care of it.
Thank you, Jen. And the next question that came up, there were some good discussions also regarding, we had talked about allowing for intranasal medications that were in several different protocols here, including seizures and things. And this discussion was brought up regarding other medications that can be given nasally or other ways of controlling seizures. Specifically, the question was raised about giving intranasal Valium, which does not seem to be effective based on the studies that we looked at. It has a erratic absorption and is not very effective. There was also then some questions that were brought up by one of the physicians who suggested that since we are giving rectal Valium and we're giving intranasal Versed or midazolam, what is the evidence behind giving rectal Versed or giving rectal Ativan, and should those be included in the protocols as alternatives? Interestingly, I actually will be happy to share this with anybody who's interested. Did a literature review and looked at some of these, and there actually are some Cochrane reviews and things on this that actually show that rectal Ativan or lorazepam actually works better than rectal Valium, and actually works better than IV Valium for terminating seizures, for that matter. And also that that midazolam given by any route, whether that's IM, rectal, buccal, or nasal, is also more effective than diazepam. So that begs the question, do we want to allow for rectal lorazepam and rectal midazolam in the protocols?
Sure.
Yeah, why not?
Basically nothing we used to do when I was in it.
I mean, it works, and so
Yeah. It works, right?
so what I'll do is
squirt it in.
yeah, just
Squirt it in.
like you would with
Why do we need that instead of just nasal though?
Yeah,
well, that
Nasal
was
seems to be,
so
it's a little more accessible.
I would think so. You have gravity on your side.
I guess the problem is if you can show that efficacy is there, then you shouldn't.
Brian,
Give it an What if you? I'm just saying. What if you have
one thing that jumped into my head about adding more uses for Ativan is that it does require refrigeration. I don't know how widespread Ativan is across our region in the ambulances.
I would agree that I think most of our agencies are not carrying Ativan for that reason, because of the refrigeration and the 60 days. Yeah,
But they're carrying Versed.
but they are carrying Versed. And I guess the question is that Ativan, lorazepam is still in our protocols, and if we are still keeping it in there for right now, even if agencies aren't, then for completeness sake, do we have to allow for it rectally? And it seems that's probably appropriate.
The other thing we need to do, and this is gonna sound ridiculous, but there needs to be an educational component if we're gonna let people start giving rectal methods.
Well, I think it's part of your
Well,
training.
we already let them do it.
It's already in your
Failure.
I just had to take a hemoglobin
But it could be
test.
part of the annual skills.
I can take it
Dr.
so
Clemency
that I can
volunteers to be a
communicate
model.
I resign effective date now as
I'll be over here if you need.
as soon as you can get the help, which is July, you have to too.
So,
What do I-
so what is
well,
the feel? I agree. I mean, I think that, you know, given the evidence, I think there's one more reason why we should
Right.
consider carrying midazolam as opposed to,
Right.
To diazepam, certainly. But, do we want to include rectal indications for both of those in the protocols?
Yeah, it probably won't be used, but we should put it in there.
All right.
That's the only way, at that moment, if you
Right.
possibly administer a medication that'll break the seizure, then you should have that option.
All right. And then the last question related to them also was about our protocols currently regarding rectal Valium doses, rectal diazepam. Is that I think we have just one dose, and it is not the currently recommended dosage, which depends on age. 2 to 5 years is 0.5 milligrams per kilogram, 6 to 11 is 0.3 milligrams per kilogram, and 12 plus is 0.2 milligrams per kilogram rectally. And should we change those doses to be
Which medication?
rectal Valium?
It's
Higher doses, correct, than what we currently have in our protocol. So do we want to define it by age, or do we want to pick the middle ground somewhere in there of like 0.3 milligrams per kilogram for all ages? Or for 2 to 5 years, it's 0.5 milligrams per kilogram. For 6 to 11, it's 0.3 milligrams per kilogram. And 12 or over, it's 0.2 milligrams per kilogram.
I think you don't separate by age. Otherwise you're doing a pretty big choice.
I mean, I think would you still limit it to the maximum adult dose of 10, I think would be reasonable.
Weekly doses.
Based on your age. The younger,
I would just pick one.
as a higher, the younger you are, the higher dose, right?
Right.
The younger you are, the higher the dose, correct.
That's the problem, you're gonna severely underdose. And who's most likely to have a pediatric seizure?
Right.
Okay.
What was the age for 0.2? 12 or higher.
Is that what the number protocol said?
I don't know. It doesn't ask for that.
But those are the recommended dosages.
Those are the recommended dosages, correct.
I think having 3 different doses.
No.
Is not the right thing.
You're guessing at the weight.
So the collaborative protocol, their region actually, I think similar to Milrem's, only uses midazolam, so they don't actually define the Valium, rectal Valium doses.
I guess I don't care as much about what the dose is, that there's only one dose. I think having 3 doses is asking for difficulty, as Scott points out correctly. A lot of guessing what the weight is in an ambulance is guessing.
A range of 0.2 per kilo to 0.5.
You want to do it as a range?
No, I'm saying, guessing the weight is probably is the same,
Already has a
produces
factor.
the same rate as this dosage.
Mhm.
So then do we want to just pick one dose? So if we're talking about between 0.2 and 0.5 milligrams, we just pick 0.3 milligrams per kilogram and leave it as one standard dose?
On these doses, that's the initial dose.
This is for diazepam.
For
You know, you're
rectal
not
Valium.
gonna kill anyone if you give too much,
No.
so we should err on the side of a larger dose. If you're gonna use it, we need the adequate dose.
And most of these teach people to away for that to bedazzle. So
So the consensus is we want to go to a higher dose
I would use the higher dose.
of 0.5 or 0.4?
Just lowball the weight.
Math is easier.
Do we have one of our feeds people on the phone?
No.
I make the motion whatever Josette says is a source of truth.
Yeah.
And we ask her tomorrow.
What's the range? The range is all the way from
0.2 to 0.5.
0.2 to 0.5.
And 0.5, mind you, is for the younger age,
Okay,
correct?
so let's do the 4.
I would
Yeah.
defer, I would make a motion to defer to the consensus between Doctors Toysher and Kennedy. And whatever they say. my motion to continue to carry on.
They may want to go with the 3 doses.
Well, I don't think they will. If they do, then we'll bring it.
Tell them they have to pick one dose. Encourage you to pick one dose they're willing to do.
I don't think we should make a decision for that.
Without their input.
Yeah, whatever they, I think we can.
Do we have a,
whatever they say,
do we have a
can
suggestion that we want to suggest to them to see if they're okay with that?
Yeah, we should recommend the 0.4, if we all agree.
That's fine.
We're talking about the difference between.
What?
No, we would max
No,
out
we
at
max
the,
out the adult dose.
at the adult
Right.
dose of 10 milligrams.
Every pediatric dose maxes out at the
Right.
adult dose. Anywhere in the protocol.
But good point.
All right, any other discussions about that?
I just got one other thing.
Yes, go ahead.
So, and again, we've talked about this in different meetings over the last couple of years, and I don't know if we need to change the wording or just clarify it in the minutes, or maybe we don't make any changes. The understanding has been that for the adult pain, nausea, sedation protocol, that intubation is not a painful procedure, right? Because there's its own protocol for it, so you can't give some benzo to prepare someone for that painful procedure. However, someone who's already intubated, like in a interfacility transfer, it is reasonable to give a standing order benzo to keep that person sedated should they start breathing over the vent.
So we're clarifying the difference between sedation for an intubated patient and a medication facilitated
Right.
intubation protocol,
So-
which already exists.
So my question is, I don't even know if we need to, I don't think we even need to change the wording, but maybe even just put in the minutes that that's our continued position on it, unless anyone has any other thoughts. But that's my understanding of the way it's been set up since this new format came out. This is the way I answer providers, but the question came up again in this revisions. So I want to bring it to the group, make sure we're all on the same page.
It should be in the preface of the protocols. Putting things in minutes, that's nice, but you just don't have access to that
Or
stuff
maybe put it in the
when you
box,
go to
put it in the box.
Yeah.
Underneath the key points.
Yeah.
Something like that. I think that's a distinction that should be made, in both directions, that people know they can do it for intubated patients, should they start breathing above the vent and causing trouble, and know to not do it to drop a tube.
What's their facility and one is pre-hospital?
Theoretically, you could
Yeah.
intubate somebody who could be unconscious,
Right.
and now all of a sudden you've blown up their CO2, and now they're intubated and starting to move around.
transport.
I mean, it's possible you could un-CO2 narcose someone, or start breathing for them, or something like that.
Is this a standing order, though, that they have, or is this something that?
It is standing
It
order.
is the standing order is for benzos for what's called, I think it says painful procedure or something like that. So it's not designed to like sedate a psychotic patient on standing orders, but I think for someone already intubated, and again, these patients should all have waveform capnography ahead of time, and should have all this other stuff. So I guess my recommendation would be to add a key point to clarify that, unless anyone has other questions or
Or
suggestions.
to add it within the parentheses for painful procedures or patients.
Who are already intubated.
intubated. I put it above, I would put it within there. And not
Or
all the way
intubated
down.
with confirmed waveform capnography.
Or should
Now
it
we're getting a
be,
little long there.
Yeah.
Sorry.
or should
I
it
just
just
think
be in the airway procedure?
That's what it is.
I would put it right in that airway procedure.
I mean, the protocol is called sedation, adult pain, nausea, sedation. I think that's where people would look for it, would be under sedation.
The only problem with that is flipping between two protocols.
Yeah.
I mean, let's just say that new medic who's reading your
Yeah.
protocol as you're like getting registered. Right?
Yeah.
I mean, then you're like, hold on, I gotta check sedation. I mean, that's a practical thing. That
You put it.
I don't think it
list of
hurts
both.
to put it in both.
I don't have a strong feeling.
I would say,
That's fine.
I would say list it as a key point in both.
That's fine.
Not as to put it in the top, because if you put it there, then people are gonna read it as sedation, think it only applies to intubated patients.
That's
I
fair.
don't think we want
Okay.
that.
That's fair.
Alright.
But if it's a directive in the airway protocol, if it's a directive to use, you should provide dosing and groups within the protocol as opposed to a key point referring.
Well,
to
there's
someone.
a sedation protocol. It's just
But
clarifying
we're
what
not-
sedation is for.
We're not telling them to do it, we're just saying you cannot use the sedation policy as,
Yeah, but if the goal here is to have all the information needed to carry out a procedure or go down a pathway on one protocol, if the key point is referring you to the sedation protocol to sedate the recently intubated patient, still going to be different protocols. So I would suggest that we add a post-intubation and sedation section on the airway protocol and include the sedation options we have on the pain-nausea sedation protocol.
I would agree with that.
So you want to add all of the sedation options under the MFI protocol?
No, the post-intubation, yes. And those are basically, you take an accommodated output sedation, so it's basically backstops. That would need to be copied onto this.
So the MFI protocol, not the regular airway protocol.
The MFI he's talking about.
No, well, that doesn't address, they're already on the MFI protocol. That doesn't address the patient that was once unconscious and didn't have a gag reflex and accepted an ET tube, who is now
Can
waiting.
Just for precedence, the way it's listed in other policies is it does it when there's something like that, like let's say the airway policies, and then it does then refer to C CPAP policy, C this policy. And so if we're gonna start doing that, then we'd have to go back and do that for everything, as opposed to just putting in a line that says C sedation policy for continued sedation after intubation.
Yeah, you know, we sometimes get in trouble when we have the same thing in different policies. We'll update one, and then we won't
Not go back
update the other because, you know, we might, and so, I think it should be.
I understand that it adds a layer of complexity, but.
Right, it does. I think introducing introducing it in the airway protocol, and just so they know they can do it, I don't think we need to list the dosages as long as they can have a place to refer for the dosages on a different policy.
What are the providers in the providers? I mean,
I think it would be easier to just put C sedation protocol. And it's consistent, because I mean, at that point, if your patient is intubated and they're starting to buck the tube a little bit, you have a few seconds to page through. It's not like an emergent situation where you're panicking. I think you have enough time to, and it just makes, if you add too much in the keynotes, it just convolutes them.
Or ideally, you know the protocols, you don't.
Well,
Or-
ideally, the new
I think
medic
we're
being a
scrolling
panic,
now.
it may have a little
This
bit
is
of
not
weight.
going to be a common event.
Hopefully.
Given, we're putting it into the emergent airway, individuals is not being transported, interfacility transport, or, right, assignment. Right?
Hopefully, most of the people we're intubating are just waking up.
Right.
Spontaneous.
But again, they can always use these protocols. They can always, you know, someone with an interfacility transport can always default back to the 911
Sure.
protocols.
So add a key point to the airway protocol.
But as a key point on the bottom, or do you want it listed underneath the intubation as a parenthesis, as another bullet? Key point? Okay, that refers to the sedation policy for both MFI and the airway.
Yeah, we'll verify it.
Well, the MFI protocol has it at the bottom.
So just to the airway. Okay. Okay.
Dr. Walters,
Yes, sir.
while you're on the airway and key points for clarification, we had discussion last night in our paramedic class about, between two different instructors, the REMAC protocol says for ET tubes, you get 2 attempts and then you must use waveform capnography. But it doesn't clearly indicate that the intention is to use waveform capnography with the bailout supraglottic devices. One of the meetings I was at, that was discussed, and that was the idea, but we're reviewing the protocol. I mean, it's up to you guys what you want, but it really isn't clear if you're going to require that for LMAs and King tubes and combi tubes, or
So
just for ET tubes.
right. So the reason that came about that way was at the time that they started mandating waveform capnography, not every agency had it. And if you recall, a number of agencies actually stopped providing endotracheal intubation and only started providing alternate airways to not have to buy waveform capnography. I think that's a bad thing, but that was what came down from the mountain, from Albany.
So the other concern is,
So
let's
it
remember
is my
that.
strong recommendation to use, in my own agencies, it is our strong recommendation that we should do that.
Correct.
And I think it's a reasonable standard of care, but that's the history behind
And-
why that was done.
And let's not forget that we may have AEMT agencies that do supraglottic devices but are not doing endotracheal intubation.
Right.
And so,
And
and they
don't have
are not
cardiac
required, do not
monitors.
have cardiac monitors and do not have waveform capnography and are not required to. And so there's a big, expense incurred with that. I think that was some of the other discussion at the state level also. So while I would tend to take Dr. Clemency's position that, and I think we've had this discussion in other areas, that it should be an internal policy if you have, in your own agency, if you have the equipment to recommend for its use routinely with supraglottic devices, but I don't think that it should be required in a REMAC policy at this point.
Okay, I just wanted to clarify. Thank you.
And there's
Is
just
is that your understanding too?
No, it's totally different.
Okay.
there were some other suggestions just about some clarification of some wordings and things that I'm not going to go through. There was a question brought up about, is our orogastric and nasogastric tubes a CC and higher scope of practice, or are they at the AEMT level? And the state says that, and the national standards both say that they are not in the AEMT scope of practice.
Correct.
Thank you. And there was another question about, just going back to CPAP for a second, the indications in the policy, it said, indications for use, greater than 10, if severe respiratory distress defined as at least 2 of the following, and the question was, is that with or without oxygen? And if you actually refer to the draft of the state policy, it actually does specify after they've been placed on oxygen, so we'll change the wording to coincide with that as well. And I think most of the other things were minor wording changes and grammatical errors, misplaced bullets, and spelling errors that have since been corrected. Although I will say that those were things that were in existence under the old policies, and I will blame Dr. Clemency for all of those errors.
Fair. That's fair.
Dr. Walter,
Yes, sir.
the one thing, I forgot to send it to you in writing, I know we talked about it, but the current excited delirium protocol goes directly against state policy, so I didn't know if you wanted to fix that or leave it. But basically, we have ketamine as a standing order for CCs and paramedics, and state policy says ketamine has to be online controlled and only paramedics. So as long as we're making changes, I didn't know if you wanted to address that or not.
So I think that you're correct that the state policy does now require, as it sits, that anytime ketamine is given, it does have to be under direct medical control. This policy was actually taken after the Monroe Livingston policy that put it in almost written as a standing order like this, that was approved by the CMAC, as were these protocols. And while it is somewhat confusing, I don't think that there was, I think the intent was appropriately placed of wording it the way that it is, based on the direction of further anticipation of uses for ketamine and meetings with what they're trying to set up with the Bureau of Narcotics Enforcement. So I think that as long as we have very few agencies right now that carry ketamine and they're aware of the requirement that they have to call online medical control, I would personally not recommend changing it the way it's written right now. Anyone else? No.
Must we entertain the idea of putting it under only paramedic? I would be. I would lean more in that direction.
Because it's
I
how
think
it's
I
written
have
right
it
now.
here somewhere.
Under critical care and paramedic.
What does the state policy say regarding that?
Policy 10-04. Other conditions for approval says, it's limited to paramedics.
Yeah, we have it as only paramedic.
So the state policy limits it to paramedics, is that correct? No, it's under, that allows both CCs and paramedics.
Oh, yeah, you're right.
So Ron, the state policy requires it to be at the paramedic level, is that correct?
Yeah, under conditions for approval, point 4, it says only those individuals certified as a paramedic level may administer ketamine. And then point 8 is bold letters, it says ketamine may only be administered to a patient under a direct online order from a medical control physician. And then the only reason I came across this is we're going through the process to get ketamine here.
Correct.
I'm
So-
concerned that if we think it's going to change down the road, I'm not going to worry about it. I don't know if Mary Raymo would catch that.
Yeah, it's the Bureau of EMS policy 1004. So then, here, Brian, I pass this down to you. So then, the suggestion is, should we move, right now it's listed under CC and paramedic in that protocol, should we move ketamine down to a paramedic only?
I'd be more supportive
Yes.
of that.
I would say yes, because if you're using the state stance on copying and stealing from other people's protocols. No one does it recognize critical periods. So,
Thank you for the clarification.
Now you're just goading me. You're just trying to get me to say something. I'm not gonna take the bait.
All right, all right, any other discussion on that? Okay, the last suggestion was, we talked about, we're going to get to in a second, the destination policy, and we had talked about, times of transfer to trauma centers. Our protocol currently says 45 minutes, although looking at the STACS recommendation and the BLS policy, it actually says 60 minutes from time of injury to a trauma center. And so the suggestion was, as we're updating these, we also update our trauma protocol and just change that time to 60 minutes from point of injury.
Again, sort of the same argument as we made earlier. The highlight areas are supposed to just highlight the best of the BLS protocol, not to be different. So that's what it says we should change.
All right. Any other, yes?
Just because I was on the Sacramento Rural County a couple weeks ago, and they brought up the fact that in the protocol, there's consistency as to state protocol, BLS protocol versus the ALS protocol. And I just looked it up as an example. Chest pains, it doesn't say in there to call ALS. Now, certainly, most places are on automatic discussion. But in other areas, such as symptomatic bradycardia, it does say to call ALS. So I'm not sure if the new protocols address that. But they were sort of like, well, wait a minute, if I look at the REMAC protocol, I don't have to call ALS. And I'm like, well, no, state protocol, these should basically mimic the state BLS for that BLS section. So
right.
I'm not sure exactly where those differences
when Dr. Myers designed this many years ago, the intention was to highlight a few key points of the BLS protocol.
Gotcha.
So if something is not there but it is in the BLS protocol, it doesn't mean it's not the case.
Right.
It just means that whoever the authors were did not find that as one of the points that they thought to focus on.
Right.
So the two should never conflict. We should absolutely defer to the BLS version, but people shouldn't say just because that's not there, it doesn't mean you shouldn't do it.
I mean, I shouldn't have clarified it with the
Yeah.
agency. And if you look at, one does say ALS, one doesn't
Right.
say, and
Right.
it's just something, maybe the new protocols address it, maybe it's even a key point
Yeah.
somewhere. I'm not sure what the fix is or if it's actually
Right.
even necessary, but it's just a point that I said that I would bring up for that.
All right. Any other comments or discussion about all of the aforementioned protocol changes? If not, then with those suggested changes added to these, that were previously discussed, I will entertain a motion to accept all of these protocol changes.
So moved.
All in favor? Can we get like an aye?
Aye.
Thanks. All right. Any opposed? And the motion carries. Moving on to the next one on the agenda is the destination policy and recommendations. This has been discussed for, I don't know how many months since Dr. Clemency was chair, gave up and handed it to me. We've circulated the discussion of the destination policy.
Can I see it?
Yeah, Josh gave up.
It should be in your packet.
Yeah.
I just had what I brought.
Well, here, you know what I have? I think I have one
Since we've
online.
discussed this over and over multiple times, there were a couple of suggestions that I think are very minor and just some clarification of wordings and things. One was from the Department of Health and really came down to was about the section that says other specialties about providers may recommend a particular destination, and the question was that the suggestion was that providers should not be able to recommend a particular destination. So this section was reworded to allow for I can read it to you as it's been stated. One second here. It's been reworded to say, for patients who do not meet any of the prior criteria, but whom providers anticipate the patient will require specialty services, providers may transport the patient to a particular destination after consultation and recommendations from medical control. These are only recommendations, and providers may not override the patient request without contacting medical control. I think that will appease the state. You're texting and driving, so I'm not sure. All right, good. Other than that, the
I
other.
don't know, I think it's fine the way it's written. I mean.
Well, if I could channel Richard Krause though, I'm sorry. If someone could just review like the syntax and so on, because there are things capitalized that shouldn't be and things that aren't capitalized that should be, and then there's some things that should be plural that are singular, and I mean, there's just, it's not bad, but I think it can be cleaned up. I'd be happy to look at it, or if
That's
whoever
what I was
wrote it
gonna
can
ask.
do it,
Fantastic.
that's fine. I mean, there's not that much, it's very simple, but just to make it a little clean. But I do have can I just mention a couple things?
Absolutely.
That I don't think I have anything major. On the first paragraph, that middle line, unfortunately, these competing factors often create situations which frustrate patients, hospitals, and providers. You see that line?
Mm-hmm.
I don't think that should be in the policy.
Agreed.
And the next one, the STEMI, no, I don't, well, I mean, that's an example of just syntax. That STEMI needs to be defined there. It's defined later on, but not there. But I can clean that up if you like. The second paragraph under general guidelines, patient request, that starts with Air Medical Services.
Mm-hmm.
That it ends with if use of the helicopter would speed a patient's arrival to the hospital capable of providing definitive care, and this is felt to be significant to the patient's condition, it just doesn't sound right to me. And I wonder if we can just lop off the end of that and just period after definitive care.
I would say no.
I mean, who's feeling that? Is that medical control? Is that the provider? It just doesn't sound right. So maybe I'm reading it wrong.
I think it should. I mean, I think that it should read something. This is felt to be of significant benefit to the patient's condition. But again, whose feeling is it? Is the question. Brian or Josh, do you have a? Okay.
We were talking about specific timeframes, or I understand where you're. I see where you're coming from.
Yeah.
One, you could look at it to say, well, maybe speeds the patient's arrival to the hospital the majority of the time, but does it provide a benefit to the patient? I think leaving subjectivity in, like if the provider feels or thinks that something may potentially benefit the patient, I mean, they're going to do it anyway. I think.
Well, how about we just add for the benefit of the patient?
Perfect.
Instead of that.
I mean, if you can get a patient to a trauma center or a STEMI center within 60 minutes by air, when it would be an hour and a half by land, then it's.
I don't think you need to say that if the provider thinks it's better for the patient. That we should
I agree.
You shouldn't need to say that.
That quotation comes from the state process.
Comes right from 505. Yeah.
505.
What, the way it's worded now?
Yes.
Oh, well, okay, I'll defer to that. If it's badly worded at the state level, then we can do the same. Okay.
Where's Scott? Was it you that had given some suggestions to the Bureau for other work to do? Is this? So, do we want to clarify that statement? Or do we want to just leave it as a direct?
I think Glenn Tershel only had mentioned about.
I would say just for the benefit of the patient, makes it crystal clear.
Okay.
And then I've always had this question. We refer to trauma triage guidelines, but the actual name is called the Guidelines for Field Triage of Injured Patients, according to, I don't know if that's the state or the CDC or both.
The state copied the CDC.
Yeah. So it's really, I wonder if we should just call it what it is, and that's what it is.
Okay, wait,
It really doesn't have the word trauma in there.
That's what they call that long name. Yeah.
Or the GFTIP. But that's the official name, and I would suggest we stick with the official name.
I'm sorry, Steve. Go back for a second. You said, how did you want to change the end of that last sentence under Air Medical
Just
Services?
to add. Hang on, let me get back to where it is. Okay, after definitive care, just add for the benefit of the patient.
Okay.
By the way, we all know what PCI is, but that needs to be defined. And I'm not, what is it, percutaneous
Coronary intervention.
Maybe we don't know.
coronary intervention.
While we're on the STEMI topic, on the third paragraph under general guidelines, patient request, on the fourth line,
We've used the terminology designated STEMI center before, and I don't necessarily know if we should
Change
put
it to
that
PCI.
there. I think, yeah, but there, I think it would be nice if there were designated STEMI centers. But we should put more appropriate terminology in there, such as hospital capable of providing 24/7 emergent PCI.
Because there's no designated STEMI centers.
Or we,
That terminology had been in the protocols for a while, and it's really not accurate.
What did it say in the state BLS?
I don't
think
think
it's
it's in
protocol
there.
for STEMIs, because
Yeah.
it's an ALS.
They've never
What it is.
defined them.
They wouldn't know if it was a STEMI or not.
That's true.
It's just Chesapeake.
Fair enough.
Not to go backwards, but the one we just changed with the air medical, why are we rewording ours to be not exactly the state's word? What is the benefit? When everything else we do, we worry about using the same wording as the BLS state protocols, but for this, we want to change it.
We didn't.
I thought we said it was the state. We
We
said
did change it.
This is the state's wording.
That one.
They
It
just
is,
said-
yeah.
They
The
just
next
said to
one was.
change it. So why are we changing from the states to not the states? If our entire goal is to be consistent with state policy and wording.
I think
Because it's
once we
listed
were-
right
I take
here.
no ownership of these.
No, I know, I mean, just because it's in the
which,
policy.
Kevin, which one are you referring to?
This is the state. word.
That's the state.
That is the state
State
policy,
wording.
word for word.
Oh,
I think we
And we're
just have to-
referencing it
Kevin,
in.
Kevin, after we realized we were referencing state policy.
No, the last thing they said.
No, we did change it.
That's what I'm saying. It got
we did change it.
quickly. We don't want all those things.
So unchanged.
So we want to change.
Well,
that.
I mean, this is just wording that, I'm not sure this is as important as these other things that we're talking about.
It should be the same as the state policy, especially if we're.
And
we're
we want to keep the concepts of the state, we don't necessarily have to keep bad language of the state.
I don't know.
I mean, I guess it doesn't change the intent.
Right.
Right.
I think it clarifies it if we change it.
I also don't think it makes a difference.
And we shouldn't be hashing out semantics here either during the meeting.
Good point.
So just conceptually, the designated center should be trauma or stroke.
Wait, 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 before we go to that, so just tell me how are we changing that air medical phrase or are we leaving it?
My vote is not to change it, because the state has a policy to argue with the state.
So, yeah, the state policy though doesn't refer to STEMI centers or anything like that, because it was written in 2005, long before STEMI centers existed. So that initial section of talking about critical STEMI, trauma, or stroke, none of that exists in the policy statement. So if, I think the language that there is trying to bring 2005 to the present, but not necessarily changing what it's doing.
Well, the policy statement section, the policy statement does reference STEMI in there.
0505? I got it right here.
Under section 2, critically ill medical patients.
No, I'm talking about the state 05. The state's 0505 doesn't reference it. The state's helicopter policy.
Yeah, that's it.
I'm sorry, I said stroke. I apologize. It doesn't say stroke, but it does say STEMI. Sorry. I didn't scroll far enough. You're right.
Because the state in its wisdom has never come up with criteria to designate a STEMI center.
There's really only one key procedure that you need to be able to provide to be one.
But yet they reference it in their protocol, they don't define it.
They call
And
it-
every time that we want to put in something about a stroke center, they complain about
That we've opened.
state stroke center versus
they-
comprehensive.
So
but-
they say critically ill medical patients requiring care at a specialty center to include but not limited to acute stroke or ST elevation MI. That's how it says. That's how they say it.
Can you read that again, Brian?
Sure. So it says critically ill medical patients requiring care at a specialty center to include but not limited to acute stroke or ST elevation MI as defined in the New York State protocols.
And that's for helicopter transport?
Yeah, I'm not sure how ST.
They don't have trauma in there?
It's still listed separately.
The other part,
That's
so
a
it's,
separate-
yeah, so it's got trauma in one, right? The trauma in one part.
And burn is separate.
Yeah. Yep.
All right, in the interest of time, since there seems to be a lot of, yet again, wording discrepancies and suggestions on how the policy is rolled out, it has therefore been given to a ad hoc subcommittee at the discretion of the chairman to Dr. Clemency, Dr. Lynch, and Dr. Lacombe.
Are you punishing us for opening our mouths?
No, I think you have great ideas, and I think that they should be included in this policy before we officially adopt it, is what I think. Yes, Josh?
I worry that doing that is going to further delay this from getting anywhere.
I worry that as well.
So we're not debating concepts, but we're just debating semantics, which
that was my point.
That's all. I think the majority of the content in this document conceptually is ready. I think we got hung up on whether we should, in the middle paragraph of general guidelines, that really we're hung up on two things that don't necessarily require a committee to figure out. One is that should we word this equivalent to the state policy, which I think the consensus was yes, even though it was a lot of words. And the second part is, bless you, is that we just shouldn't list STEMI Center as a designated center. It should be listed on here as a hospital capable of providing 24/7 PCI. I don't know that there's more work beyond those two.
There is one thing, it's kind of minor, but I think it was left off because I thought it was on an earlier version, but under psychiatric patients, there's the 9, we mentioned 941, but there's also 943, which is someone directed to go to a hospital by a judge, and a 945, someone directed to go to a hospital by a community service person, and we should just throw those in because they may be part of the mix in sending patients to the hospital. I think it was on an earlier version. I don't recall.
Just put the caveat, like review the wording because I'm not sure. I think I looked this up recently, and 945 do not have to go to 939 or 940 the same. They can go anywhere.
Actually, a 941 doesn't have to go to it.
That's what I mean. There's some.
I thought a 945 did, but 941 did.
It's one of those. That's all. Yeah. The state's very specific. This one too, which was the go where they've been building up stuff.
So you want to potentially add 945 in there? Add or Cindy, does a 941, does it have to go to a state of designated?
I don't think so.
I don't think it does.
I think it needs to go to a hospital.
Exactly,
Right.
as they do in Jamestown. Right.
Unfortunately, they can go anywhere.
Right. So you want to add 945 in here somewhere?
And 943. One's directed by a judge, the other one's directed by community service, director of community services.
And then we go back to other specialties.
Okay, wait, hang on. So I'm going to add, so then if I just say where it says patients on 941/945/943 steps.
Right, right.
Would that be okay?
That'd be fine.
Okay. I'm sorry, going back where, Dr. Clemency?
So we touched on a second, then we just went past it, but our other specialties, I think it's fine the way it's written right now. I think if you have a 5-year-old, I think the crew should absolutely be able to say, your 5-year-old should go to Children's. I think if you have an open mangled hand, you should say, you should go to ECMC where there's hand. And it's just a recommendation. It's the language here is soft, that doesn't override patient consent, but I don't think you, as a BLS EMT, have to call medical direction in order to tell a parent not to bring their 6-year-old to Buffalo General. To me, that just seems like common sense.
And if they do demand that you take them to Buffalo General and you feel strongly about it, you can call for medical direction.
Right.
I agree with Dr. Clemens.
So I mean, I think it's already has the second sentence that these are only recommendations. Providers may not override patient requests without contacting medical control. But or if someone says, "Hey, all my cares and sisters, where do you think I should go today?" I think the provider should say, "Sisters sounds good."
Instead of, "I can't tell you."
You should say, "I can't tell you. Let me call medical direction and ask." Like,
I think that's going to happen whether it's in here or not.
Right.
But Greg Young makes a good point. They should not be recommending facilities, and that's what he specifically said in response to this.
well, why not?
Well, he said this is what he says. They do not.
Point
Oh, he's on the
that's
line.
not familiar with services available. And I gotta tell you, if they recommend taking a patient to a facility, there's a bad outcome, there's a subsequent suit, and it turns out that the EMT made the recommendation, they're gonna be held liable. And it's gonna be the EMT's certificate that gets lost in the shuffle. Roll back to medical control.
So do we just delete that section?
You know, I think they're gonna do it anyway.
I think it's better to delete it than
Yeah.
take it all
Yeah.
out.
Try to reword.
I'd rather.
Yeah, I think it's best out.
What are we taking out?
Just that providers are recommending where to go in some cases. It's at the bottom, I think.
I think so.
Okay. No, I mean, it's true. I mean, that's how you write a policy.
Theoretically, then they would call for medical direction if the answer is
Right.
not here.
I just have a
Theoretically.
question under stroke centers, and I know it's gonna sound territorial, and I understand the language. But if arrival at a stroke center is greater than 2 hours from last seen normal contact medical control, to determine the appropriate destination, as patient may qualify for extended thrombolytic window at a nearby stroke center, or may benefit from services at a more comprehensive stroke center with endovascular capabilities beyond the traditional window. Will medical control refer them to the closest stroke center with that capability, or will they bypass?
So I understand your concern, and this language was put in there specifically to allow, we acknowledge, and someone correct me if I'm wrong, that there are 2 hospitals in the area that have received comprehensive designated stroke center designations, which are not officially recognized by the state, correct? And so we wanted to actually encourage them to go to one of those 2 facilities, not one preferentially over the other. However, the feeling of the state was that we could not encourage them to go there specifically in a policy because they are not officially recognized in a state designation as a comprehensive stroke center.
Well, all stroke centers in New York State are equal,
Right.
Yes.
which we know is not.
Is not the case.
Not
And
the
so this
case.
wording was put in there to get them to go either to Buffalo General or Mercy, basically.
Right. There was a much more strongly worded draft. And then this is the very watered down.
Yes.
But even
But I think we're all on the same
It
page.
still
as
has
you,
some
Rich.
concern, depending on where the medical direction, I suppose, is coming from.
No, I think you would have liked the old version better, I'm saying. The old version was, go to one of those 2 places. And in weakening that language, I can see where.
it's still going to be medical, whoever they get who enters the phone for medical direction.
It would
Ultimately will have a significant amount of influence as to where they end up transported.
I hope that in those cases, providers, just like they would call a STEMI center, they would call the comprehensive stroke center for their medical direction. If they don't have something.
Which they have the ability to do.
Most
Yeah,
agencies,
correct.
they don't have base, some agencies still have base station control. But the majority do not.
I know you were involved in these discussions. I think this whole group here sitting at the table agrees with you. Just so you know.
The language came from this group, though?
The language was changed after the Department of Health was not happy with the way it was initially worded because they do not recognize comprehensive stroke centers.
Right.
Which
Just
we,
like I
as a
said,
group of
take them
EMS
to a
physicians,
comprehensive
feel that
stroke
these
center.
patients benefit from going to a comprehensive stroke center.
Yeah, I would think that we would all want to go to one of those centers.
Right.
Correct.
Right. So.
All the language,
That's
that
where-
language came from this group, the revised language came from this group just after the state's recommendation that we need.
Right. If I had my way, it would just say go to a comprehensive stroke center, full stop. Right.
And go to the closest one.
Which to me makes the most sense.
All right. So there is, I think, one other point to discuss that was brought up, and this is under critical patients. And the wording says unstable patients, particularly those with an unstable airway and or in cardiac arrest, require urgent intervention and stabilization. The most time-sensitive patients should be taken to the closest appropriate New York State certified hospital emergency department, and then refers them to the BLS protocol for further details. This wording, closest appropriate New York State certified hospital, comes right out of the BLS protocol.
Brian,
Again,
where are you?
I am on, under critical patients.
Critical patients.
Oh, okay, first page.
So this wording comes right out of the state BLS protocol. There was concerns from the Department of Health that we should take out the word appropriate. However, closest appropriate is actually the wording in the state BLS protocol.
you may
Well, the
actually.
policy has always been that an unstable airway goes to the closest hospital.
Who wants to take out appropriate?
The Department of Health. But it's in their state BLS protocol. Go ahead. So let me give you a scenario,
I mean, if you
I'm
have
gonna
a,
give you two scenarios and just to put it in perspective, and then we can talk about the wording. So here's my suggestion. If you are relatively equidistant, I don't think you should be bypassing something that's 20 minutes away, but if you're relatively close to several hospitals in the city of Buffalo, let's say, and you have a trauma code, is there a benefit of taking that code to ECMC? And I think we would all say standard practice is that we go to ECMC. And I think that if you resuscitate them,
it depends on the time of travel and the instability of the airway.
it depends on several factors, but I think that there may be times when you resuscitate them that it may be beneficial to be there. And I'll give you another scenario. Is let's say that you've got a confirmed STEMI who codes on the way when you're on the way to a PCI center that is relatively the same distance as another center. Is it okay to bypass that? Because we know that there are PCI centers in the nation now that are doing interventions on people during cardiac arrest. And so I think that there should be some language to allow for some.
I guess the other scenario is if you have an emergency department that's staffed by a mid-level versus an emergency department that's staffed by a physician.
I think, I don't disagree with that thought, but I think that none of the hospitals that are predominantly staffed by mid-level providers are anywhere near any other hospitals.
Some truth to that, yes.
You know, so operationally in our region, it's not so much of a concern. The other suggestion we discussed was to replace the word appropriate with the word generally. Should take it generally to the closest New York State certified hospital. Does that perhaps fix some of your problems and doing so add a different layer of confusion, not the one we're trying to stop?
Right. I think the intent is that based on the specifics of the case, that we do not want to pigeonhole somebody to the closest versus closest appropriate if the condition warrants. And that's the discussion. Dean, you got a suggestion? Okay.
We may need to entertain the idea of taking New York State out of there as well. And the reason I say that is there are departments in southwestern New York State
Oh, yeah.
That's
that
a good
are
point.
actually closer to
Yeah,
Hamlet than,
good point.
So, yeah, let's just.
anywhere else.
So then should we just leave it as
Clyburn,
closest appropriate hospital emergency department?
I mean, how
I
strongly
still don't know
is
why
the
you need
state
appropriate.
making us take it out or just suggesting?
They're suggesting.
The word appropriate was put in years ago when we did the BLS protocols, and I was one of the authors. That was back in, 1990, 1989. At that point, it was for exactly the reasons you all are discussing. And of course, they haven't really been updated. CMAC hasn't touched them, and, well, maybe made some slight changes to them. So we don't have, the state's official position is it's up to the REMAC to define appropriate. And the only reason we use New York State Article 28 or New York State designated hospitals is we write protocols for New York State. We don't write it for Pennsylvania. Obviously, if you've got a patient on the border or close to the border that's in an arrest and it's closer to make it to Erie or wherever, I hope the judgment is you'll take them to the closest facility. But it's up to you guys. If you're equidistant, sure. I mean, that's where the word appropriate comes in. So you're allowed discretion.
Let's try New York State certified.
Okay.
I don't know if that helps, but that's sort of the background.
Thank you, Greg. So then we'll take out New York State certified, correct? And leave it as closest appropriate hospital emergency department? Okay. Just as a point to Dr. Falk's point, earlier on the first page in the last paragraph, we do say, if the closest appropriate hospital or closest specially designated center is outside New York State and that hospital has received the appropriate certification by another state and or applicable accredited body, the patient should be transported to that facility. All right.
Right, I just was looking up the 939, 940 stuff.
Yes.
And per the way it's referenced to section A of 939, 940. A 9.40 facility is a CPAP only, and a 939 facility has to be designated by the Commissioner of Health. So I don't think it could be any facility. For those, so anything, any one of those laws, like 941 papers or 945 papers, stated that it has to go to a 939 section A facility or a 940 facility, which is a CPAP. So I think it mandates that all these ones go. We can verify that before we finalize.
Yeah.
I just want to be specific, because we don't want to force people, like Josh is talking, 40 minutes away.
Right.
Because we
Same
wrote a
thing as
policy
this one
wrong,
too.
but you also don't want to send them to a local hospital, which is technically against the mental health code. So I think we really have to make sure we double check that one last time.
Should say, should say to the hospital at the direction of the 941 agents.
That's not true, though. The 941 agency is not determined, so they have to follow the law. The law states that facility can go to. If the cop says go to the VA, you can't do that. So you can't listen to the cop. You have to listen to the law.
But I think to Josh's point, there are areas both there and I think in the southern tier, there are hospitals there are routinely transports from police on 941 papers to hospitals that are not.
I agree. I said we just need to make sure that our policies comply with the law. You can't say, yeah, don't listen to the law, go wherever you want to go. Because if they're on
No, I
papers,
agree.
then they're in custody technically. So you have to follow the law. Just make sure.
We still.
One more comment about mental health patients,
Yes,
that
we always have them.
Yeah, I mean, it always has been. I didn't-
correspondence
changed.
and
So
some
the
discussions
stroke
with
gets
the
through in the south towns, they're gonna call most of
Yes.
to the title track,
Yes.
the mental health director of Wyoming County. And we had talked about some frequent flyer psychiatric patients, and they, this is not necessarily a REMAC decision, but we should be aware that there are health departments out there, county health departments out there, that feel that when they have a contract, signed patient care contract with patients, that may determine things like destination, whether even if the patient disagrees where you want them, where they want to be transported at the time of them calling 911. So this is not an ongoing problem for me, but it certainly may present itself to others at the table or on the phone, that there may be patients, psychiatric patients out there that have contracts signed with a county health department, that they have agreed to only be transported to a certain hospital.
If they agree, they should be on papers if they agree.
Exactly.
And it's a voluntary, and
Exactly.
if you're voluntary, you can go to any facility you want to in the world.
So they may change their mind when they call 911 that they would like to go somewhere else. However, some health departments may discuss with the EMS agency that the contract is binding, even if the correct.
Just if they ever don't have it. Patient won't volunteer.
If they don't want to go to the hospital that they've agreed to go to.
There's no way to.
So does that need to be addressed in here?
Do you wanna look at other specialties? Patients who do not meet any of the prior criteria, but whom providers anticipate the patients will. You already took that
Take it
out?
all out.
All right.
And just for wording, how do you want to word STEMI centers? We want to call the 24/7.
24/7. Yeah, PCI
PCI
capable.
Mr. Walter, does that contradict the current REMAC protocols to say PCI capable?
What does it say?
PCI capable, there's no reference to 24/7.
There are hospitals that are PCI capable during the daytime and not at night.
No, guys, just to give you background on that, when we wrote the regs, any center that's designated as PCI capable under state regs now has to offer 24/7 or they're not capable. So there was a conscious decision made to not designate them as STEMI centers, only they're called PCI centers, and the REMAC can then transport your STEMIs to the appropriate PCI centers that you choose to within your region. But all PCI centers in New York State have to be 24/7 as of, I think it was about 2 years ago.
I'm sorry.
Do you know of any?
If there's an exception you're aware of, I'd like to know about it, because that needs to be
No,
looked into.
not that I'm aware of.
You know, because like ECMC is a diagnostic but not therapeutic lab, so they don't count as a PCI center.
Yeah, we do 24/7 at Mercy, Colida does.
Right, and then Olean is the third. At
Right.
VA.
So we don't need to change 24/7.
Just PCI capable.
PCI capable.
Will the VA sort of, or?
I can tell you
Does the
this,
VA do it?
currently
VA?
They are 24-hour capable, however, they are in the process of updating and changing equipment, so there will probably be a notice of that goes down. We're putting in two cardiologists, 24 hours.
since we left the word appropriate with critical patient.
Okay.
So if you would keep it or leave it.
Okay, then we'll just leave it as
As long as the word.
Any other suggestions or comments on the newly amended REMAC destination policy? Going on its 10th month in
We'll
review.
never hear about it.
No. Then, given those suggestions today, can I have a motion and a second to approve this?
So moved.
Dr. Cooley, I see your hand there, Kevin? All right, all in favor?
Aye.
Aye. Any opposed? Thank you for the love of God. Moving on, I think in the interest of time, we're going to I guess we're on to the provider privilege application policy. So, Scott, you want to talk briefly about this?
So we're now into our third year of implementation of the REMAC provider privilege and continuing medical education policy. At the last REMAC meeting, there was a lengthy discussion regarding what happens to services that do not submit their provider lists and I guess proof of training, if you will, that the annual skills are complete, that everybody has valid CPR certification and other alphabet soup cards per their level of care. And some of the experiences that the program agencies have had over the last couple of years with regard to compliance and records and so forth. The discussion that took place at the previous meeting was what happens when they don't submit by August 1st. The program agencies are contractors. We can do as little or as much as the REMAC and our regional councils direct us to do. But whatever we do, we need to make sure that we have, I guess, a clear protocol or clear guidance in terms of what we are supposed to do when the date comes and it goes. This group expressed frustration at the previous meeting with regard to why are we allowing agencies to continue to stay online after August 1st. When the deadline is August 1st, you have a year to get the stuff into us, get it in, and if you don't, then we need to take additional steps. So under the direction of the REMAC from the previous meeting, the program agencies had a number of discussions, and we've taken the liberty of making revisions to the REMAC policy based on what our discussions were, and then also some of the prior discussions at REMAC meetings dating back to last summer when we were encountering some of these challenges. The revised policy is included in everybody's packet here, but I can tell you, just in summary, we had to define what restrictions meant, whether it was partial or whether it was full, whether it was specific to ALS. So some of that language is in there. And unfortunately, I think the only way to do this is just to kind of walk through each of the changes. Anything that was changed is in red. Anything that's in black is not new. There's no change to it. So starting at the top, there was some consideration that's given here that it's all agencies operating at all levels of care that fall within this policy. I think the one thing that we probably need to sort out a little bit here is that what that really means is it's anybody with the New York State EMS code. So that would include BLS first response agencies, it would include transporting ambulance services and ALS first response agencies. Anybody that doesn't have a state EMS code, they can have a defibrillator, which means they might have an EHCP, but they can't have EpiPens, they can't have albuterol, they can't have other things that would otherwise require a medical director. So the language that was proposed was all agencies at all levels of care. I don't know if we want to clarify that further to include anything about state EMS codes or not. I would defer to the group. This was actually language that Dr. Walters had suggested in the revision. Thoughts? Okay, hearing none, we'll leave it as is. Moving on to the next section where they talk about the provider privilege application. Providers must meet all of the didactic and skill requirements for his or her level of certification, and it must be done on a yearly basis. Any agency that fails to comply with the policy may be taken offline and may be required to attend a REMAC review hearing. This stems back to a discussion that took place last September when we were reviewing the list of non-compliant agencies, and there was actually a suggestion made that an agency that has failed to submit the required information would not be placed back online once they submit everything, because that doesn't really give you any teeth in your policy. All it means is that, well, I didn't get it to you on August 1st. I made you do all this extra work, and I gave it to you on August 3rd, so now I'm back online August 4th, and then we're going to go through this whole charade again next year. And so the idea behind this was to further encourage agencies to be compliant with this. If you don't have your stuff in by August 1st, the program agencies are going to be directed to take the agency offline, which means that they don't have a provision to provide care under the authority of the REMAC. It means that they don't go back online until they appear before a hearing board of the REMAC, which basically will ask, why did you not submit this? And make it, I guess, a little bit painful for them so that it doesn't happen again in the future. And as a part of taking the agency offline, it would also necessitate communication with the town officials wherever they service, meaning that they would be aware that their fire department or their EMS agency is not permitted to operate under the authority of the REMAC, and that they should make arrangements for mutual aid to be there to provide care. So this is what I would consider to be the biggest change that we have here.
So they don't necessarily have to go to a hearing. It says they may be required.
Right. That's correct. But I think to not do it would be self-defeating of the policy, but it certainly would give the REMAC the ability that if we've discovered that maybe that wasn't the best approach, it gives you an out in future years to change it. Or maybe you go the other way around.
Mm-hmm.
You know.
Okay.
Right. I think if somebody is out of compliance and they submit the paperwork and they comply, then obviously they don't have to come in for a hearing. The suggestion was actually made, I think it was Mr. Gill's suggestion several meetings ago when an agency didn't comply, that we maybe offer them the opportunity to come in and sit in front of the REMAC and discuss this. And so I think that was a great suggestion, and it's in here.
Also gives you the flexibility if you know you're working with that agency and there's some issue that you're trying to resolve, even though it is late, it does give you this. If you have previous knowledge that there's an issue and they're trying their best to get it done, but they can't by a week or so, I think that has to make an individual decision based on the circumstances.
Right. I guess the only point that I will take the liberty of speaking on behalf of all three program agencies, whatever the process is going to be, we have to know this up front. Because when we notify an agency, we're doing this on your behalf, when we notify an agency that they're being taken offline for non-compliance with the policy, we need to know that if you submit your stuff, that we're going to put you back online and you don't have to go to a hearing, or if you submit it, you're still offline until you go to the hearing. I think we need very clear guidance from you in terms of what you want to occur.
Well, while you have, the wording that appropriate elected officials basically need to ensure proper planning during the service's absence, I just, if you're real restrictive in this policy, you could create some difficult situations for coverage in an area.
Which is in previous meetings, one of the discussions in some of the previous meetings, what we discussed is exactly this. But how do you oversee and make sure people stay credentialed and carry out your duties of credentialing providers without having to stick as well to say, if you don't do it, you're in trouble.
Right. So the discussion is, and I guess there's a difference here, is that if a provider in an agency does not submit their paperwork, that provider is offline if the agency has submitted the paperwork for everyone else. Right. In the past, there have been entire agencies that have not submitted any paperwork on anyone, and this then says that that agency should be taken offline as a whole. And I think that's appropriate, because I don't think that we should allow entire agencies to just ignore the good policies.
Right.
Would it maybe be, better to have the agency's medical director take them offline because they're practicing under his or her license, so they have much more of a, if the result isn't as positive, they have every right to do that under all circumstances.
They do have every right to do that, although I think in the interest of trying to standardize things across the 8 counties in the REMAC, I think that we've made the decision that we want to stand united and present one clear, concise policy for that. I think that certainly the medical directors, who have had this discussion before, should be notified early and get involved in cases where paperwork is not submitted on time, either for individual providers or agencies. But I think that it's important that this policy comes from the REMAC and addresses it across the whole region. Greg?
I'm just curious, and I think the role of the program agency is to facilitate help and work with the providers. Having them deliver this message might not be the best for them to do. Is it somehow the responsibility of the actual REMCO that should be delivering the good news to the agency?
I believe that the program agencies are also, part of their job is to carry out the work of the REMCOs, is it not?
Well,
The REMS goes in.
anyway.
Right.
Greg,
It would be coming from
the notice itself actually is coming from the REMAC.
Okay.
And it says to contact your program agency to get this information in, but the notice itself actually is coming from the REMAC. There's a draft of it, but that, yeah, I agree.
You were gonna
Thank
do it
you.
anyway.
Thank you.
Remember what I agreed to last?
So the next section is offline, means that an agency or a provider is restricted from performing procedures, treatments, and therapies. And then it breaks the restrictions into a full restriction, which is everything, ALS restriction, which means they can do BLS only, and then partial restriction, which is something where a provider, can't perform under standing orders, and so forth. So that was just a classification, and there's some spillover now that from this policy into the provider restriction policy that is 2013-2, but it just helps to create continuity between the two documents, and that language was missing and was felt that it needed to be in there. Moving right, yeah.
Can you give an example of a situation where a partial restriction would be appropriate?
So if you had a provider who performed a skill as a standing order, but maybe they gave the wrong dose of the medication. They gave the right drug, but they gave the wrong dose, and you don't want them to function with the autonomy on their own. You want them to be able to call
For an individual provider.
for an individual
So why is
provider.
it in this policy? I think is what his question is. Not why is it in the provider policy, but why is it?
Because it's a level of offline, and maybe this language needs to also be included in the other policy too, but it's, and maybe.
This is a state policy, correct?
Yeah, the language might have come out of there.
So the partial events from the state, word for word.
I believe so.
That one just came out, so I'm not 100% up with it. But now a medical director could have the option of not wanting the standing orders for all the providers in the agency. Maybe it's a brand new ALS agency, and the providers are all relatively new, and they don't want to give standing orders to anybody. So it could be an agency-wide partial restriction.
So I guess the question is that we're saying in this paragraph here, it says, a provider who is not entirely compliant with this policy shall be considered offline, but we don't define what that offline means, and then we give these suggestions down here below. And if we're talking about a policy that's a credentialing policy, not something that's related to they gave the wrong drug or dosage, does this language need to be in there?
I think so. You're talking about individual providers in this lesson as well as full agencies. And if the policy covers both, then yes, there is a both portion. I just want to make sure. Like if this policy oversees an individual person not filling out their provider privilege.
Right, but if they didn't turn that in, then would they just be offline?
It seems like it should be an all or none.
Are they gonna
Either
fill out
they're online or
Right,
offline,
okay.
period.
I'm fine with that.
Specific to
I'm
this
just
policy.
asking, 'cause that was my question, is what Because then you're saying that anytime somebody is not in compliance, we need to specify in a letter we send to them which one of these criteria they meet. And my thought is that if they're not sending in they're not meeting these requirements, they're offline.
I guess from an ALS restriction standpoint, you could have an agency that maybe has 2 ALS providers who are still certified, but they didn't do their skills. Those 2 providers are offline, so you have an agency that has BLS providers only, but they're certified to the, or credentialed to the ALS level. They would be on ALS restriction at that point.
Just a question about this policy. Is there a committee that's working on this? Or who-
This is the 3 program agencies got together to draft it.
I'm just getting a little concerned that it's already 3 o'clock and we have 15 new item agenda points here, and there's a lot of changes in addition to this policy to try to hash through right now. If it's the group's consensus that this must be done now,
We had a long discussion at the last meeting, if you remember, it was probably 45 minutes or so about this policy, and the discussion was then to give it back to the 3 program agencies to draft suggested changes and that, which they did meet, thank you, and we got together on, this is what they had come up with. So is your suggestion you want to?
is there a reason if we table this until May? Something happens?
No, because we still have until, I mean, the deadline is still
Yeah. I think
June 30th.
So I think I agree with Josh's statement should move on, but I think we should get together and talk about this again before the next meeting.
I think a couple of docs need to be involved.
I think we all need to be have an understanding exactly what we want to have happen on August 1st,
Yeah.
and then that should inform the document.
Yeah.
Sort of. I think we're sort of in the other direction. I think these are all good suggestions, but I think we all need to be 100% on the same page of what we think is going to happen on August 1st, and then kind of mess it up. So I would agree that moving on and having a meeting in a couple weeks is probably the right thing to do.
So I'll make a motion to table this until May with discussions in the interim involving several of the REMAC members. We don't necessarily need to be decided.
Yeah, so then, why don't we forward this out to all the REMAC members, and why don't you maybe set up a conference call and invite anybody who wants to participate?
Perfect.
Okay, the one thing I will suggest is that on this one here, it should be number 2, and should be indented. Just for numbering.
Gotcha.
All right, very good. The helicopter utilization policy, I think that we need to disseminate that again before we approve it, but do you want to say a couple words just specifically about the changes or where it came from?
Yeah, okay. Yeah, we're not going to spend a lot of time on this because well, I'll just say, so the helicopter utilization policy, there's 3 policies. The REMAC has one on the website, the REMAC, there's one in the protocol, and the state has one. So there's been a lot of discussion online, and we decided obviously we're going to meld the 2 REMAC ones together. Don Trepaz just sent it out last night or today. I just found it today. He did some work and created 2 drafts. One is a state, and the other one.
Suggestion to the state amendments to their policy 0505, and the other one is a suggestion to the change to the REMAC protocol.
Right. So he just sent that. Did you send that last night or today?
This morning.
Okay. So we really haven't had a chance to look at that. So I don't think we should really have any more discussion. But I just want to, the only point that I think we should clarify before this subcommittee does our thing online again is, there is a state policy. Okay, that's, and we're going to make suggestions to the state to make it better. Should we have a separate REMAC policy, or should we have, and I'm kind of in favor, I mean, I don't, policies are a pain in the neck, and I don't see why the state should have one and we should have our own. They really should be the same. So should we have our own separate policy, or should we have, I don't know what you would call it, a policy statement or something saying we're following the state except blah, blah, blah. Because there's a couple, for instance, the state says someone in cardiac arrest, unless they're hypothermic, shall not be transported. So they're giving a little wiggle room to transport a hypothermic cardiac arrest patient, whereas our local policy is nobody in cardiac arrest will be transported. That's an example of where we would differ with the state.
So my opinion, I guess, would be that if we are talking about following the state policy, except in certain instances, then we just created our own policy. Right?
Well, that's what I'm asking, just for guidance for the subcommittee. Should we have our own totally separate policy that's pretty much identical with the state except for these few points? Or should we just have some kind of statement saying, refer to the state except for these areas?
I think, go ahead.
I would suggest that being familiar with the CMAC and the SEMSCO workflow, as a member of the CMAC,
Speed of sound?
I would say that, I would recommend that in the interest of time, we work diligently to develop and create a policy that works well for us, with the intention of taking this to the CMAC and the SEMSCO in the hopes of kind of revising the state policy to get to a place that mirrors ours. And if that needs changes at the state level, then perhaps we consider changing ours. But I think ours will be formalized far sooner than the CMAC or SEMSCO would ever be able to do that.
Have you seen how quickly we implemented the destination policy?
Correct. I'm not changing my statement. I still think.
No, I agree with that, and I think the other point is that right now, we do have some helicopter guidelines in the protocol, and if we do adopt the collaborative protocols as we've discussed next year, then those, we still should probably have our own REMAC specific helicopter policy, I would say, and I would tend to agree with Josh with that, so.
I would be happy to have our policy sent to the collaborative group for consideration that they adopt a similar policy or the same policy. But I think that waiting for the state to adopt theirs, to modify theirs, considering it's made in '05, probably, I think we owe it to ourselves and to our providers to come up with something quicker than this.
So can we send it back to our ad hoc committee?
Yeah, what I'll do is did you send that just to me or did it go to
Well,
the?
that went to the collaborative.
Okay, so everyone has a copy, so we should all look at that and then.
Not the whole REMAC,
No.
so we'll send it out
No, it's
to the
just the
REMAC.
group, there's 5 or 6 of us
We'll
that I think.
modify it, or we'll hash through it and then send it to the REMAC.
Yeah, with time to review before the next meeting. All right. Moving right along, new REMAC website suggestions, if you have any, please provide them to Donna or submit them online as we're trying to make the website more user-friendly. I think it's getting there, but I think there's still some things we need to button up. Under new business, what? Yeah,
New
eating
bus-
sandwiches.
we're now on
that's
new
the one.
business.
Under new business, approval of the REMAC representative change for St. Joe's to Chris Project.
Motion for approval.
Second.
In a second, all in favor?
Aye.
Any opposed? Motion carries. Congratulations to Dr. Patrick. Yeah, the REMAC meeting, next meeting will be May 20th, and it's going to be, Donna, are you on the line still? No. I believe it's going to be at the All-Star Training Center in Jamestown, and I think that they're working on some type of lunch or something like that, and we will send out confirmation and directions to everybody. Donna's been working on that. The base station course will be held July
Snow be
2nd
melted by- I hope so.
at Erie County Training Academy. Brian, do you have anything to add to that, or
It'll be in the morning.
it'll be in the morning? All right,
clean up
that's
nice.
just a notification. There is a requirement, a state policy, that all emergency room physicians who give medical control have to attend a base station course, so just as a point of information. Moving on to, we're gonna go out of order for a second to EMS pre-hospital notification. Dr. Lynch?
This will be brief, I promise. We are working on some patient flow processes at North Suburban, and we have noticed that notification of incoming patients has really dwindled. And it's useful to us if we are notified of patients incoming, especially those that may need something like BiPAP or significant staff resources. And we're just asking if you're bringing patients to Suburban, that especially someone who might require a fair amount of resources, please call us ahead of time. And if you call us ahead of time and are met with resistance via either the phone or when you walk through the door, please direct any issues to myself, and I'm happy to bring it back to the administration. That's it. Unless there's questions or concerns.
Nope.
Thank you.
REMAC policy 2002-1, Dr. Clemente.
So, this is perhaps the most poorly titled REMAC policy that we have. Because this is the one you have to look for the 30-minute rule for offloading your patient, but you'll never find it if you search by titles. I think we need to revisit this. In January, I had a conference call with representatives from the state. That was the time, that many of you remember, where everybody was sick with the flu and all the EDs in Buffalo were backed up because all the hospitals, rooms upstairs were backed up. And we were looking for solutions. And we sort of brainstormed on that call a number of possibilities to offload patients more quickly. And then, unfortunately, a larger, bigger picture answer didn't really come out of that call. I believe that if you come in your own car or you arrive via EMS, that should not determine how you wait for a room after being triaged. I think if you were healthy enough to sit in a chair in the waiting room, if you drove yourself to the hospital, you should be healthy enough to sit in a chair even if you came by ambulance. If you're acutely ill and you come in your own car, you should be whisked back right away. And I think there's this double standard that we've created. Yes, it is probably better for every patient to be sitting on a stretcher being watched by a crew member, but it's not better for that same crew member to not be back in their district to answer the next 911 call. So I think that we should have a meeting between now and the next meeting with perhaps the Nurse Advisory Committee and perhaps representatives from the state on both the EMS and the hospital side. It's lunacy that we're allowing our ambulances to sit in hallways for an hour, hour and a half with no end in sight.
So I will say that this came up on also an email from Dr. Young and from the department brought up a similar concern, and this doesn't apply just to city or, the greater Buffalo area services, but also to some of the farther out services doing interfacility transfers. And so I think it is an issue that needs to be addressed, and I think it's appropriate to do so.
I just have a question to the other physicians. So, and we do it. Does everyone, on occasion, you get someone come by ambulance who's not sick, send them to triage?
And put them in the waiting room?
Everyone
Yes.
does that?
Yeah, we do that at Mercy.
Okay.
Yeah, I think we could all, myself, my own hospitals included, I think we could all do that a lot more than we do right now.
And there's all kinds of issues with patients getting care from the EMS staff. We don't want that either.
Right.
In the hospital.
Right.
Correct. Ongoing care that you're saying is maybe outside their scope of practice or pushing beyond it a little bit?
Dr. Young, are you still on?
Greg, are you still on the phone? No.
It comes from him, and I
Right.
think it's more that it's the responsibility of the hospital to take care of that patient at
Right.
that point, and where scope of practice and what permission they
Right.
have to, do they still use protocols when they're standing in the line, and those kinds of issues.
So I'll just sort of tell you the direction that I would like us to see us go in, and then we'll move on. But I would like us to go in a position where if you're there for more than whatever the time is, 30 minutes, 45 minutes, whatever it is, you can offload your patient and inform, not ask for permission, of the emergency department staff.
You're making an assumption there's a place to offload a patient.
There are chairs.
Not always.
Not always.
No. Then I think that's a failure of us as hospitals then.
Right.
Well, there's no question.
Right.
But I think the hospitals, and I include my own in this, so I'm not trying to point to anyone else. I think we are, cutting staff, or we're choosing how many beds to purchase, or do all these things on the backs of the EMS agencies. And the EMS agencies have nothing they can do because they're stuck with the patient. So I just don't think that's appropriate.
Now, if there's a hallway bed, is there a time limit we have to put that patient in a hallway bed, or is that off limits, or is it, they're not, is that? Like
Right now it says 30 minutes. That's what the policy says right now. I think we should put patients in hallway beds. I think that's where I think the hospitals should accommodate the EMS providers.
And I don't disagree with
Let's
that.
just say theoretically you have hallway beds.
Yeah.
That are always full because the number of the volume you have.
Then you should buy more hallway beds.
So,
I said, I got a 5-year-old ER.
Yeah.
We now have 9 hallway beds.
Right.
We have avoided it as long as we can, and we lost the battle this year.
Yeah.
Or maybe you need, we need to be more selective as to who belongs in the waiting room off an ambulance stretcher or who belongs in the back. Because I think that that problem wouldn't be solved or prevented, surely. But at some points during the day or night, maybe that problem could be lessened.
Right. I don't think there's any hospital out there that right now is using the same standard for putting people in the waiting room,
No.
whether they come in their own car or not.
No, I think.
You know, we have belly pains that we keep on a stretcher and who come by ambulance, and we have chest pain that we keep in the waiting room who come out of their own car.
Yeah, this is an interesting argument because patients are obviously much safer in the department than they are in the waiting room. But from the nursing perspective,
They don't even exist, right?
from the nursing perspective, they feel their license is at risk if they're in the department and they're responsible for that patient and something happens. And that's how they look at it, and I don't really blame them for looking at it that way. They, in a sense, they would rather have that patient in the waiting room because their license is not at risk. So that's an issue.
The reality, I'm sorry, just real quick, this is one of these policies I think that we often forget our role. We are hospital representatives at this, right? We are all assigned by our hospital to represent them and their interests, not our EMS agencies, which many of us happen to also be EMS medical directors, where we want to defend our ambulance crews and our ambulance. So I think this policy is way bigger than getting ambulances back in the street. It involves direct interaction with our hospital administration to put this, because I'm sitting here representing Collide today because that's who put me on the REMAC. Whether my opinions always, reflect that directly, that's the nature of this business. But I just want to make sure we're remembering this is directly affecting our hospitals who put us at this meeting.
So that being said, I think the consensus is that there's an issue that needs to be addressed and needs to be addressed probably at the hospital level. Is it easier for everyone to go back to their representative hospitals and say, hey, the REMAC has this policy, and use that? And I think that that's the way to leverage it. Is that?
I think this policy is a recipe for disaster.
Well, this is already there. This is not a new policy. This is the policy.
This is the one we've been failing.
Yeah, but I don't know that
Right.
it's ever really been. I've never seen a medic leave a patient with.
Can I just give a real quick background on this?
Frustration, but not on regular practice.
So this policy specifically, the services have been feeling the pain for this for obviously a very long time, and regardless of who you're here representing, working with the administration, depending on how receptive the administrator is to hearing it, is how much of a result you're going to get. What really brought this to light, and even beyond what Dr. Clemency highlighted is his prior involvement, was an agency came to me and said, we're going to go out and we're going to buy another stretcher, and we're going to leave the patient on that stretcher in the hallway at the hospital, and we're going to go back in service, and then when we get back to our hall, we're going to take our extra stretcher and put it in our ambulance. Can we do that? And so when we looked at this, and we looked at the language that was in here, it says it has to be a hospital cart. So what I had suggested to the agency was, don't spend thousands and thousands of dollars on a cart. Go out and buy one of those MASH cots that's 4 inches off the ground, and then who cares if you lose the $20 MASH cart in the hallway at the hospital? Don't lose a multi-$1,000 stretcher. But the language doesn't permit them to put the patient onto a MASH cart. I think if they had the opportunity to do that, that would be the next shortage, would be on MASH carts, because everybody in Western New York would be buying them and putting their patients on there, and people would start following the 30-minute rule. This is a big problem. It's not new, and there's not anything that we can all point the fingers at one another, but we have to realize that EMS has far fewer resources to answer 911 calls than hospitals have to be able to call people in for overtime, move patients around, board them up on the floors, do whatever has to happen. EMS doesn't have the resources to be able to compensate and to watch patients that are ultimately the responsibility of the hospitals to do.
We're going to go very quickly, Rich, and then we're going to move on.
Okay, one thing, you guys are all here representing hospitals. So representing the hospitals, I would ask for, if we are truly in that realm, that we then go back and initiate representing EMS as some form of delay status. Because right now, the EMS agencies have no clue, other than some Facebook page that the crews are all using, as to how the hospitals are delayed, and how many patients are stacked up, and the different elements that are going on. What we're doing today is not right for the patient, and it's not right for the system.
But technically, since it's the patient's choice as to where they go, it doesn't matter if it's delayed or not. You can't tell them like, well, the hospital's delayed, do you wanna change your mind? Because that goes against what we just talked about with patients choosing and versus providers telling them where to go. Yeah, that's right.
You know, Brian, the only, it's even on this policy we discussed earlier today.
Yeah, the only
It is
agency
inappropriate.
that can fix this problem really is the state. And if the state puts the pressure on hospitals, if the state, I mean, that's the only,
The state would like to be recognized.
hospitals are not going to accommodate all these patients unless they're pressured to do so.
You guys are the doctors, I'm just a dumb little old paramedic, but these patients do not belong at the hospital. These patients, if I can take that patient and I can sit them in a chair in the waiting room, they don't belong in the hospital.
I don't know if that's
So,
entirely true.
But part of the issue, again, this is why I think it needs to go back to the hospitals, the state. This is a bigger issue because the fact that EMS is mandated to transport every patient fails not to one is a huge problem. So that becomes the EMS problem because if EMS gets there and they determine that the patient just called because they didn't have a ride there, but it's not emergent, they had other options or other things in place, that would decrease the overutilization of EMS. It doesn't decrease the number of patients coming to the ER at the end because they're still getting there. But that's a problem right now that forces EMS to have to transport. So I think there's a state issue with the state policy.
It's a REMAC policy.
I'm sorry?
The REMAC policy is that they have to go to
It's
an
not-
Article
It's
28.
not our policy specifically.
It actually says both in the state protocol, unless it's an approved, REMAC approved alternate destination, and it is also reinforced somewhere in the REMAC policy.
There's a state policy that says, and I can look it up for you, but there is a state policy that says they do not have to go to an Article 28 facility as long as they go to an appropriate facility for their problem. And the REMAC has a policy that says they must go to an Article 28 facility.
It says, it's actually in the BLS protocol, and it says it approves, it allows the REMAC to approve alternate destinations, is what it approves, basically. So I think that this, obviously, there is a lot to discuss here, and I think that we're correct in that it's both involves EMS, the hospitals, I think the department needs to be represented as well, and I would suggest, I think like you had suggested a while ago, Brian, that we take this into a subcommittee and get representative parties involved, because I think it's an issue and it needs to be addressed, and I think that as a point of clarification, the REMAC's role actually has the authority to govern over EMS in the region, and that's both in Article 30 and in Bureau of EMS policies. Correct, Ed?
I missed that, I was on different tracks.
That's okay. But
Twice
it's in
today
there.
you got me.
I know, but it is in there. But we are appointed to the REMAC by individual hospitals, so it is a dual role that we, sitting on this committee, that we both represent both hospitals and the EMS in the region. So, Dr. Clemency, would you be willing to organize the representative parties and move forward on this? Sure. Thank you.
Just as a comment, I firmly believe that data does drive the system, and I think that agencies, certainly from either ADI or from the large providers in providing appropriate drop time data would be good to analyze, from a systems perspective. I'm not saying, maybe you're looking at a year, or maybe you're looking going forward, or maybe you develop a mechanism that certainly hospital drop times could be analyzed and certainly submitted to the hospitals so that they see how they compare to other facilities. If everybody's busy, everybody's busy. In addition to that, if you don't measure it, you're not gonna, anecdotally, we all know it's busy, we all know that there's certainly issues, but you should be able to break that data down between ALS and BLS drop times and see where the trends are and where the peaks are, and certainly, an emphasis on getting the ambulances turned around needs to be a priority. And whether that means that the ambulances start leaving after 30 minutes, which is the current rule, or the ambulances start billing the facilities for time spent at the facility, or another solution is developed.
That's creative.
There are other systems.
How about sleeping bags?
Correct.
They're even cheaper than
We're gonna put parking units in the hall, by the way.
Fantastic.
I should know this,
Parking meters.
I should know this, but how long does the hospital have to triage the ambulance for a ride? Is there, I don't know.
Actually, the Department of Health says 15 minutes.
There is, but they didn't know that because it was very, when I transported on Sunday, it was very obvious, the nurse told me, I can't do anything until she triages me, and she walked away and went home. Right, and I wasn't seen for another 35 minutes. And I was asking to be triaged, and they said, no, until I triage you, you know, that's not my case. I think the hospitals understand they have the responsibility to triage. And then the whole thing about saying, if you triage them and they're stable, then we can go to the waiting room. All right, then they're not stable. Then I need a room. Well, they don't need a room because they're stable. Then I have to go to the treatment on for 20 minutes. But it is, so you're saying about 15 minutes they should leave triage.
That's the standard that from the Department of Health. Correct. So, all right, so we're going to take that to subcommittee. Moving on, we already talked about the intermediate phase out. There was a question brought up about AEMTs, and I'll defer to Denise on this one, or anyone else who has.
So glad I can.
Yes, me too. Thank you. Regarding, this comes out of the PPA credentialing for AEMTs. Currently, as AEMTs can intubate and give epinephrine, first-line cardiac drugs, the question was, should they be required to take ACLS? And currently, they are not required by REMAC policy to take ACLS. And then the next follow-up question is, should they be required to take PALS?
Currently, they are not.
Currently, they're not. They are required to take a trauma course, but not ACLS or PALS.
They are not eligible for ACLS or PALS certification. To successfully complete the skills portion of those classes, you have to be able to calculate weight-based medications. You have to be familiar with all the medications that are used in the course. And while they do use epinephrine as part of what they use, they're not familiar with all of the drugs that you need to actually hold a certification in ACLS and PALS.
You're not required to monitor patients, so you're going back to teaching rhythms again. Not.
Have to be able to interpret EKGs, which is above their scope of practice.
Correct. Okay. I think it was brought up by someone, and I do understand there's some concern because our AEMTs can give first-line cardiac, they can intubate, and they're not taking ACLS, but I think that answers the questions, that it is not required. Next is, there was a question brought up by someone who's both a flight nurse and a paramedic about the required trauma and pediatric courses that we have set our equivalent under the REMAC right now, and asking if we would recognize some of the nursing courses such as TNCC and the other pediatric courses in that. There was an offline discussion, and the discussion was that we should send this. We do have an education committee, and that would be the appropriate place to discuss these issues and to evaluate the courses for equivalency. Is that the right word? Okay. Who is the chair of our education committee? Who was? Yeah.
It was Myers and
Kenyon? Okay. So I think that we'll forward it to that committee, and anyone who has an interest in that, we can put on that committee as well. Next, we're going to get to the last several things here that we can accept all in mass, correct? Yes. All right. I do have one point of clarification here under medical director change for WCA services. This is not actually a change from Connor to Walters. It is adding as an associate director. He is not, Dr. Connor will still be on as the medical director.
Okay.
All right. So that being said, all of the medical director changes, PAD notifications, epi notifications, albuterol, level of care changes, naloxone, glucometry. Do we have a motion to accept and a second to accept them all in mass?
So moved.
Second.
All in favor?
Aye.
Any opposed? Carries. And I think that is it. Any last concerns?
Things get approved so much more quickly at the end of a meeting.
Yes.
Just down.
Still a lot of discussions. Then I will accept Dr. McGee's motion to adjourn.
Rich.
Thank you all back.
Rich, so